That's right. So, as you'll know, since COVID, we've established 24/7 open access NHS urgent mental health services across the country. So that was originally in support of the COVID response back in March. We asked that all areas ensure that there was urgent mental health advice and support available to people of all ages through open access NHS 24/7 telephone helplines. So this was an ambition that was expedited. So for adults, this was meant to come into play from March 2021. And for children and young people, this wasn't meant to come into play until March 23-24. So it's a huge amount of progress done in a very short amount of time. So where we are now, we know that every area has implemented these 24/7 open access telephone services. The NHS.UK Service Finder is now live as well, which is a major development for the public, and they can find their local service, filter by age as well, through the link that's on the screen in front of you. So as we know, given that this has happened much faster than anticipated for the CYP aspect of the service, these parts of the services are less well developed than the adult services, but areas have met this priority ask by extending their hours of operation or by combining with adult crisis services to cover the 24/7 period. If you go to the next slide, please. And then Modestus, were you doing this or is it still me? Sorry, I can go through it.
I think it's Anna or yourself, Riley.
Sorry, I'll go through, no problem. So the key service principles, they are open access, so anybody can refer or self-refer. A substantial proportion of the needs should be met by the phone or through online video consultation. These phone lines enable direct access to support, advice and triage through a comprehensive assessment from a mental health professional. They should be able to access a contemporary patient record, including the care and crisis plans, and also assessment and support away from emergency departments as well, where there is no urgent physical health conditions. They should have seamless access to urgent further care in the local crisis and acute pathway. Management and signposting of referrals to alternative wellbeing support as well within the pathway. That includes local authorities, VCSE as well. And it's a universal service, so suitable adjustment, including staff training, should be made to respond to CYP and a diversity of age, identity, race and culture, and those with coexisting needs and conditions. So guidance on these process and recommendations for well-operating SPAs are found in the link that you see on your screen. Next slide, please.
Thanks, Riley. So as Riley has said, we're aware that a lot of children and young people services have accelerated really quickly to meet the 24/7 support line ask. And we do know that the services that are sitting behind these lines will be continuing to develop in line with the long-term plan ambitions. But what we've got on this slide here is just some key service principles for areas to be able to deliver an age-appropriate response. So these are principles that both children specific and also all age services will need to adhere to. So services should understand local CYP crisis needs and activity. Services may offer one single point of access for all ages, whereas others may offer a separate SPA specifically for children and young people. First response call handlers should be supported with age-appropriate training, protocols and consultation. CYP crisis response service organisations will need to reflect local needs and activity, taking account of the resources available locally. To determine how children and young people are supported across the 24/7 period through services staffed by children and young people's practitioners who are trained, competent and experienced in meeting CYP specific mental health needs, or through blended approaches across CYP MH practitioners and adult experienced practitioners who are appropriately trained and supported. Services will need to evolve over time, and the model in place now may change either as staff become available or as activity levels change. If we move to the next slide, please. Thank you. So in terms of sustainability and things to consider moving forward for children and young people services, areas are encouraged to capitalise on the acceleration of the 24/7 lines and the wider better use of remote working, and also to reflect on how you can support delivery of the broader CYP mental health crisis ambitions moving forward. Areas should also ensure that the support lines are sustained whilst the services that sit behind them continue to develop in line with the long-term plan ambitions. So because of the rapid service expansion that we've seen during the pandemic, CCGs and services are encouraged to work with STPs and ICSs to revisit their pre-COVID LTP implementation plans to reconfigure implementation timelines in line with the new services that have been established. Areas should also be starting to consider using CYP mental health local transformation plan partnerships to create post-COVID plans to maintain gains, improve access and workforce capacity, along with surge plans, and to lock in any emerging good practice. We just move to the next slide, please. Thank you. So the final CYP specific thing that I wanted to raise was a quick update on the CYP crisis survey. So the third survey was launched last week to establish the 1920 position of services for children and young people presenting with a mental health crisis. So this survey is how we monitor service provision in line with the long-term plan trajectories. So this collection will build on previous surveys and provide an update on the national, regional and local picture of crisis and intensive home treatment services. It is a voluntary collection and we have reduced this down from previous years with an extended collection window which will remain open until the 30th of September to reduce any additional burden on services during this busy time. But all services will receive a local report of their services, which will be benchmarked locally and regionally and nationally, which we hope will drive service improvement and give areas a good idea about how they're doing against the long-term plan ambition. So yeah, we're really keen to reflect all of the great work that everyone's been doing and ask everyone to work with us and NHS benchmarking to reflect full coverage across the country. If we move to the next slide, please. Thank you. So I'll hand over to Modestus now. Thanks.
Thank you, Anna. Good afternoon, everyone. And yet again, just to add to the thanks from myself and other colleagues at the national team on your fantastic effort to stand up those crisis lines to support individuals in your local areas. What a fantastic achievement, although so much more work to be done. So for next 5 to 10 minutes, I'll dwell a little bit on our national support offer to local areas, what we're thinking, what we're doing, what's the next steps. And then I'll also give you a bit of the overview of what's coming in quarters 2 to 4 in this financial year. So as you can see in front of yourselves, together with experts by experience, with national advisors, with people championing mental health in the local areas, we consulted and developed a self-assessment checklist for the newly established crisis mental health telephone lines. Although it can also be applied to services that have been running for some time, including colleagues that developed services in Sunderland, Bradford, Cambridge and Peterborough system, Hampshire, etc. I guess our overall aim has been to provide you with some sort of guidance in terms of what does good look like when it comes to telephone line support for individuals experiencing mental health crisis. We have also looked in terms of what is happening in international agenda. We looked what's happening in Australia and France, and we tried to create a very quick overview of key functions that are paramount when it comes to creating and providing that truly holistic and compassionate and engaging support for individuals in mental health crisis. And as you can see, if you'll go for a list, I would highly advise you to access the self-assessment checklist if you haven't seen so. At the bottom of the slide, and I think slides will be shared with yourselves later at some point today or tomorrow, there's also a link, because we try to promote and use the Future NHS collaboration platform. And you can also you'll be able to find many other tools, such as service specifications from the areas who already had crisis services established for some time. And at the same time, the areas will also just launch their services and they'll want to share their experiences to date. And again, I guess one of the key emphasis for myself would be capitalize on your current structures. capitalize on your crisis care concordant partnerships, A&E mental health, A&E delivery boards, and all the structure you have in the local area to make sure that that true partnership working translates into tangible outcomes and outputs that therefore can further improve the quality experienced by individuals when they have a mental health crisis. And yet again, I suppose if you'll go through the key functions on the slide, you'll see that we try to think about how does that link with primary care? How does it link with secondary mental health services? How does that link the third sector provision? Again, and yet again, being a key to making sure that we think in holistic approach and we think about the whole system working together. Next slide, please. Thank you. So again, we appreciate that a lot of hard work has happened over the last 3 months, and hard work will continue. And as I mentioned, we really appreciate that it has happened so quickly. Although at the same time, we need to think for the future and think how can we make those crisis care lines and that offer make fit for the future generations. And again, in order to get there, we need to remember the key ingredients that makes it work. So at the national level, again, working with our experts by experience and our expert reference group, we're thinking on what does good look like in terms of what should be the key performance indicators for crisis care. So we'll be consulting with yourselves via regional teams at some point very soon, but at the same time, I would like to urge you to think, what would you need to collect locally that would inform you and guide you in the ongoing development and fine-tuning of your local crisis care offer. At the same time, we are also developing a mental health services data set guidance. From historic information, we know that information and data flow on mental health services is very poor. So we're trying to work again with services that have been established for some time now and all the different mental health trusts across the country, and refine the guidance on how information should flow and how information should be reported on going forward. In addition, again, as I mentioned earlier, when I was quickly talking about the self-assessment checklist, I mentioned how important is integration with your BCS sector at the local level. Alternatives to crisis, how does that link in with your transformation funding, which has been allocated last year? Where are you thinking it needs to go next? And again, at some point, we'll be providing some fair guidance on our views at the national level. In addition, again, as you all aware, national ambition was that for all ages, NHS 111 will be a single point of access across the whole nation by 23-24. Having the crisis lines open and functioning across the country at this point in time, we need to also start thinking, how do we move that trajectory forward, and how we actually starting moving the crisis lines into 111 sooner rather than later. And that also links with our ambulance trust colleagues, and also the work what will be happening with the ambulance response program going forward. So yet again, bear with us. We're working on the guidance on how 111 links with crisis care lines. How would that work in practice? Acknowledging different models, as I mentioned earlier, Cambridge and Peterborough or Hampshire. There's different ways how to do it. The most important part is that it doesn't create any burdens for individuals accessing care. In addition, we're also conveying some extra workshops with regional colleagues and colleagues in the local areas who have established so-called mental health crisis hubs. In other words, known mental health A&Es. So again, we want to evaluate and understand whether that's something we'd like to sustain going forward, or is something that actually is redundant and wouldn't work in certain parts of the country. And yet again, we'll be working with your regional colleagues, and we'll provide you guidance as soon as it's available. In addition, as I know it's a lot of information, and we're progressing with lots of different areas. It's around training for the newly established crisis care line workforce. So we're working in conjunction with Health Education England colleagues, and we'll be doing a scoping exercise and try to understand what is currently available, where are the gaps and how can we procure a solution which is fit for purpose for the whole country. But this is not imminent solution. It will require some time, so our early outputs won't be expected by at least the beginning of next summer. In addition, also this digital agenda, as you can imagine, COVID has changed the way we live lives, the way we interact, and particularly in clinical environment. How do you support people via virtual means in terms of providing face-to-face assessment? What about the follow-ups? What about those individuals who are actually relapsing and actually really acutely unwell, and face-to-face assessment is still a preferred option? So together with NHS Digital, we're reviewing all the different solutions and applications that currently exist on the market, and we're putting some recommendations for local areas so they can procure them locally. And last but not least, again, thinking about restoration recovery, we know and fully understand that locally, in terms of operations, there's still really COVID-19 related issues happening on the front line. But we need to start thinking, how do we move in restoration recovery, and in particular addressing inequalities that exist in our communities. How do we make sure that you promote and we promote the crisis care line offer as wide as possible, so you can get people using it, accessing it, and getting the most benefit of it. And then hopefully introducing that stepped care crisis model into community setting will be able to prevent crisis from happening and support people better. So that's everything from me. I think now we have around 10 minutes for Q&A. And I think we should be opening that for questions. Thank you.
Thank you very much. We've got a couple of questions coming through. The first one is from Stephen Lowe. Is there a way of adding a tab to the NHS app for mental health that could hold the patient's crisis plan?
Stephen, I will have to take it away. And because I would suppose so, we should definitely be able to do that. Because I guess I know NHS Digital, one of the key things we're exploring at this point in time is interoperability so we can actually, and working with all the different sector providers, including ambulance services, so we can actually see the patient care plan and access it as soon as possible. But I'll take it away if that's okay, and I'll come back to you via Sylvie, if that's okay.
Yeah, that'd be great. Thank you.
Thank you. Another question from Andrea King. Are there any good examples of how CCG and LA commissioners have co-designed community crisis models that we could learn from? Very good question.
Oh, it's fantastic questions. There's many different examples, and lots of different areas have used very different approaches how to address that. So again, if you remember, in the previous slide, I referred to NHS collaboration platform. And on there's some fantastic examples of what areas have done, including the standard operating procedures in terms of how different models work. At the same time, I would like to promote positive practice of mental health directory. As you will be aware, they have the directory as a repository of everything what's available across the country. And as far as I can remember, there's a section about co-design. And they have presented, I think, over a dozen of case studies that showcases where things went really well, then different sector partners came together in co-designing the truly holistic and compassionate crisis care pathway in a community setting. I suppose I can share the link to the directory. Is that okay, Andrea?
Yes, that's terribly helpful. Thank you very much. It's just helpful for us to learn from places who've done this before. So thank you.
Another question coming through from Emma Ferguson. Money for child and adolescent health service is very small. Current use of the crisis line is very low and does not justify the significant cost of running. Will you be looking into this?
Thank you, Emma. It's a very important point that you've raised there. And I think in terms of the funding, we do have funding in baselines, and there is transformation funding available this year for services to continue with expansion. In terms of the current use of the crisis line, from previous services that we've heard from, actually current usage, it might not be reflective of the actual need that's in the population. So we've seen from a few services that have had the crisis lines up and running for quite a long time, and they're part of their pathway and integrated into other services, that once the lines become more established, people do start to access them much more in the out of hours period as well. But what I would say is, obviously local areas will know their populations and current need much more than we would nationally. So I would look at kind of the VCS integration, using adult mental health adult mental health 24/7 services, and looking at where you can upskill adult mental health practitioners as well to cover the CYP need in the out of hours period of time as well. Modestus, I don't know if you've got any reflections on that as well.
So I guess we need to, again, looking into the data and analysis that we've been conducting over the last around 5 years, we know that for children, people accessing crisis support, activity is much lesser compared to adults. So if we look around that 100% scale, around 10 to 15% would be children people. Nevertheless, again, there's different models that exist in the country. So there's some areas who decided to go separate crisis line directly to children people services. There's some other service models where actually, it's universal service, which covers all different ages, with expertise and experience of the practitioners that work in children and adolescent services. So, but again, just to reflect on what Anna said, I suppose the money is there. It's coming into baselines in both shapes and forms in terms of transformation funding as well. And I would just urge to explore the different models and try to apply the one that fits the best for your local population.
You've probably got time for a couple of more questions. So one from Lee Sawkins. How is the NHS long-term plan working with police support forces in meeting the high levels of mental health related problems on police resources?
Yeah, so I can probably come in here. Another really good question, thank you. So you would have seen in the long-term plan that we also have an ambition to improve the response that the ambulance service provides to people who are in mental health crisis. But actually, one of the reasons that came about is that we recognise that police forces as well end up, when people are calling 111 or 999, sometimes it's the police that are responding to these mental health crises, and that isn't, always the appropriate response. So part of that that ambition provides an uplift in CCG baselines. So that will help to improve the education and training of the undergraduate and also the existing ambulance workforce around mental health crisis and responding to that. Also funding that can go into put mental health professionals in 111 and 999 call centres, or to fund models such as street triage, which also in some areas includes police, paramedics and mental health professionals. And it also, depending on the capital spending review, will fund a fleet of mental health specific vehicles, which we've worked with colleagues in the police sector to design, as well as including our ambulance colleagues and service users as well. So they're very much involved in that programme as we go through too. So that baseline funding came into play this year and will continue until 23-24. And we are currently developing kind of case studies of good practice in all of the different areas, initiatives that ambulance trusts are already taking. That should then help, if we have better trained paramedics and ambulance staff, that should then help people who are in crisis, reduce the amount of people that are conveyed to emergency departments, reduce the amount of people that are responded to by the police, and make sure they get the appropriate care that they need, either on the phone or by being responded directly by a mental health professional or a very well trained ambulance paramedic as well.
Just cutting in 1 minute left of this section, Sylvie.
Yep. So final question I think we can address quickly. It's a question for Modestus. Will the crisis training for practitioners include training, alignment with social care and safeguarding, as local reports are that children and young people crisis lines are receiving disproportionate number of safeguarding and social care related issues?
First question answer would be absolutely yes. Because training will be for all ages, for everyone, including the CS sector, because we know models in delivering crisis care support in the community highly varies across the nation. But again, as I mentioned, it's not a deliverable that will happen very quickly. So I guess the first step will be scope out everything what's available across the nation, and then try to put that in some sort of training program and framework, which then therefore could be commissioned nationwide. But absolutely, training and alignment with social care and safeguarding is at the core and will definitely be included. That would be my reflection at this point in time.
Thank you. Thank you, Riley, Anna and Modestus, for a fantastic presentation. If we don't manage to cover all the questions, as I've previously mentioned, we will collate them and circulate them with answers after the event. I'm now going to hand over to Sonia McLean, who's from Hampshire and Isle of Wight, partnership with CCGs. Thank you, Sonia.
Hiya, thank you, Sylvie, and thank you, Alec. So I'm Sonia McLean. I'm a Senior Commissioning Manager across Hampshire and the Isle of Wight, and we have a mental health triage service which is co-located in our NHS and 111 and 909 provision. So just a word of warning, I'm struggling with bandwidth at home. However, Terry Simpson is on the line and he is from SCAS, and we're going to play tag team. So if you lose me, Terry will take over. So hopefully I can also answer some of your questions that you've raised here as well about digital police response and ambulance sort of mental health response as well. So Alec, next slide please. So Hampshire and the Isle of Wight have got a population of just over 2 million individuals. We've got quite a large sort of geography that we cover, and we have two major cities, so Portsmouth and Southampton, along with the West Hampshire region, which is quite an urban sort of area. So we've got quite a lot of mix of deprivation, health inequalities, and what we wanted to deliver is one single service that literally meets all of that for our footprint. Within our service, we've also included Surrey Heath, the grey bit right on the end. So they joined our service in June, and the reason why they've joined our footprint is purely because South Central Ambulance and the 111 provision covers Surrey Heath, so it made sense that they also had the support of our mental health triage team as well. Next slide, Alec, please. So just wanted to bore you all with some statistics really with regards to depression, SMI and dementia. So as you can see on the right hand side, you've got the statistics for England, and then you've got where we are across our areas with regards to our local sort of stats. This is from 2018, but I think it provides quite a very clear overview where some areas are higher than national average and some areas are lower as well. Next slide, please. So thanks to Sylvie and James's team, they developed a lovely infographic for us on the long-term plan, which very clearly showed what we needed to be able to achieve for mental health. And as you can see, one of those was NHS 111 and that access to 24-hour care. We were in a very fortunate position across Hampshire and the Isle of Wight that when our long-term plan came out, we had already implemented our service, but we have made a number of advancements since that time. So developing that single point of access, which is exactly what Riley and I have talked about before. And on the next slide, Alec. Oh yeah, a little circle around that. And if you put, there's another little circle that comes up on the ambulance one, which talks about ambulance staff being trained in crisis response, mental health nurses in the control room, and the introduction of mental health vehicles. So our mental health nurses are employed by Southern Health NHS Foundation Trust. Southern Health support about 70% of our population with regards to mental health provision, but we actually do support 5 mental health trusts in its entirety. We've got a secure mental health transport provider in Hampshire called Secure Care UK, and they support our secure mental health transport movements. So people who've been detained under Section 136 or been detained under Section 2-3 and those sort of community treatment orders and things like that. We don't use our ambulance provision for that service across Hampshire and the Isle of Wight. We have a dedicated commissioned contract for that. Next slide, please. So the mental health triage service for us offers advice for people who are phoning NHS 111 as we provide specialist mental health nurses in that provision. The mental health nurses support the clinical triage and assessment of both children, young people, adults and older people. So it's an ageless service. And this provides a consistent and reliable service across our ICS footprint. One of the questions that was raised by, I think it was Seth, was about the algorithm in NHS 111. And actually we have experienced no issues with regards to the mental health algorithm in NHS 111. And all of those mental health symptoms and discriminators go through to the mental health triage team. So I'll go through those in the slide. So we conducted a soft launch of this service back in December 18, where we were testing the service out with Band 6 mental health nurses, and we then implemented the service 24/7 in February 19. Next slide, please. So the challenges to the implementation were really understanding the activity and demand profile. So what activity was going into our crisis teams, what activity was going into 111 and to 999, and also that mental health activity that was going through to our police forces, because as we know and we've heard nationally, the police mop up the mental health sort of response, but actually so does our 111 and our 999 providers as well. They support a huge amount of mental health calls that actually aren't recognised as data or activity with, through to our crisis teams. So the business case brought all of that together, as well as the activity that was going through to GP out of hours, and some of that activity that we were able to substantiate through primary care in hours. Once we secured the funding, it was very much about winning hearts and minds, and sometimes that was a bit of a challenge because, again, you were also then moving staff away from crisis and community settings and putting them into another sort of environment. But we were very lucky, I think, across Hampshire and the Isle of Wight, as we did win those hearts and minds. Like I said, we've got 5 mental health providers that we feed across our area. So it's not as simple as having one local authority, one mental health provider. We had 5. So we had to agree an interoperability information sharing agreement, which allowed the mental health nurses to have access to all of those mental health systems. So they were well informed on care plans, crisis plans, when that person had been seen last, or what interventions had been potentially happened over the last 48 hours. So we had information sharing agreements in place with all of those, which, to be honest, were quite tough to get. But actually, I feel confident that I've done the hard work for others to be able to share that. And then it was just getting the workforce in place and then agreeing the standard operating procedures as well. So next slide. So we have STP-wide funding for the delivery of this service, and we were also very fortunate to get NHS England transformation funding to continue to enhance this service for that open sort of access service. We are exceptionally valued to be able, or valued is probably the wrong word, lucky to be able to be completely embedded within our 111 and 999 provision. So we do share the same provider for both of 1s and 9s. And we, as a consequence to that, we are able to, at no cost to ourselves, all the developments that are happening with regards to NHS 111, we've been able to piggyback on with that as well. With this service is completely in line in collaboration with our police force. So we got funding from our Police and Crime Commissioner because he recognised that our business case could absolutely support the deployment of our police officers and how they would be able to get informed mental health advice and guidance when they were in the community, when they were potentially going to detain somebody under the Mental Health Act, how we could look at least restrictive practice, so not then having to actually detain somebody under the Mental Health Act. Like I said, we've got standard operating procedure with all of those 5 mental health providers. We've got data privacy impact assessments with all of those, as well as seamless referrals. So we are able to refer into AMHT. We're able to refer, if we absolutely need to, into liaison, into community mental health. And one of the collaborations that we've just agreed in the last couple of weeks is with No Limits. So we're testing No Limits, which is our children and young people sort of voluntary sector organisation, the direct referral into No Limits, where they'll then contact the child and their family back within 48 hours of that referral. We've got a dedicated team leader who's been instrumental in leading the mental health nurses, along with the head of operations within Southern, who leads the overall overarching service. Next slide, please.
No problem, Sonia. Just doing that. Just so you know, you've got 5 minutes left of presentation and 5 minutes left of questioning.
I've got to whit along quickly then. Okay, so really quickly, this is a boring bit. So this is DOS profiling. So on the directory of service, all of these symptom groups have been profiled, so they'll go through to the mental health nurses. They're quite extensive. There's about 500, if not more, of mental health symptoms that go directly to the 111 sort of mental health triage team. If you go to the next slide, what you would have seen previously on the left-hand side of that box is where those mental health symptoms would have gone before. So ED, primary care, pharmacy for medication, ambulance potentially being called, or a clinician in 111 phoning that patient back. Now what you get is the mental health nurses being able to do all of those interactions with those patients. Next slide, Alec. So the flow, very quickly, we've been able to add in NHS 111 online. So the green bit is the function that we have for online. So as the patient goes through, they'll call 111, they'll speak to a health advisor, they'll be asked questions about their health, so they'll go through the NHS Pathways algorithm. The mental health nurse will call them back within a time frame based on their clinical presentation, and in that time, in the main, the mental health nurse is also checking on the computer systems with whatever sort of area that person's phoning in, and then the mental health nurse will phone the patient back and then agree what the sort of plan would be for that individual, depending on their clinical presentation. So next slide. So this is just some data. So quickly giving you some data, I won't tend to go through it too much with you. So as you can see, on average, SCAS managed about 400 mental health calls a month. And as you can see, from when the mental health triage service went in, the calls accelerated massively. They have actually gone massively back up again. So we're seeing about 12 or 1300 calls a month. And this service goes alongside those single point of accesses that are currently within our area, as well as sort of the acute mental health services that are available as well. On the next slide, we've got the outcomes for NHS 111 online. So we, again, like I said, we're really fortunate to be able to use the NHS 111 online platform. So this is a very quick snapshot of when we implemented this in April, of the contacts that we've had going through the platform itself. So this is a massive benefit to us. So thank you to the NHS Digital team for really helping us to accelerate this response. Next slide. So patient outcomes, so really quickly, following that person's interaction with the mental health triage team, the mental health nurses have been able to reduce the patient's original endpoint. So we've seen an 80% reduction in ambulance dispatches for Category 3 and Category 4 ambulance dispositions, a 97% reduction in recommended to attend ED endpoints. So this is where the patient would have been advised to go to the emergency department had the mental health nurses not had an interaction with them. 70% reduction in primary care endpoints, and the home treatment element to this service has been massively improved the outcomes for our patients, really. So previously, SCAS clinicians would support these calls, and we had about 11% of home management. Now it's up to 69%. What's really important to say at this point is ultimately patients will still choose to go where they want to go, whether that's primary care or the emergency department. We can't say to them that they can't do that, but what we're saying is based on the clinical outcomes of their calls, they no longer need to use that avenue as support because they've been supported over the phone. Terry, did you want to come in here?
I can, if just a couple of brief observations from an ambulance perspective, if that's helpful, Sonia. Obviously, the ambulance service is increasingly being seen as the front door to urgent and emergency care, and I think having that embedded relationship with Sonia and Southern Health gives us the platform to really build and navigate a system response. So by doing that, that helps us with frequent caller management and containment and distress tolerance. It helps us with developing and delivering mental health triage cares that aren't just either police or ambulance centric but system centric. So just on the back of Lee's comment earlier on from the police service, the ambulance service does have a very high level of mental health activity too. So if we can get the transport right, the triage right, and the telephone navigation process right, it really gives us an important role from a system perspective in reducing place of safeties, ED attendance and liaison psychiatry. So I just really wanted to emphasise that the ambulance service can be a really key player in the future of mental health crisis provision.
Thank you, Terry. Sorry, I want to quickly rattle along because I want to make sure we cover it all because it's really quite important. So next slide, Alex. Sorry, and I will shut up, I promise. There's a disposition in 111 called DX92, which tells a patient to attend, after they've had their clinical assessment, attend the emergency department immediately for a crisis mental health assessment. And actually, this was a big disposition for us that we wanted to reverse straight away. And as you can see, after that individual's had the assessment from the mental health nurse, 72% of those individuals are now treated with home management and self-care, and only 25% of those are advised to go to the emergency department because their physical presentation is deemed them as needing that physical sort of check from the emergency department. Next slide, please. So again, this was just showing some of those mental health outcomes. I won't go into them too much. We'll just move on to the slides. You'll all get the presentation anyway, and I'm happy to take some questions afterwards. This is just showing some of the impact to our emergency departments and or not so impact, but we could have potentially seen a massive additional rise in the increase of our emergency department presentations and our top 3 presentations that we do see within our emergency departments. So next slide. And then this slide really sees the increase in demand across our local areas with regards to 111 calls. So again, overall, we've seen a 62% increase in mental health demand across our 111 provision. But actually the next slide shows a 28% reduction in our 999 call demand in relation to mental health. And as you can see from a previous slide, we can see that that's really helping in regards to deployments of ambulances as well. Next slide, please. And this is just a really quick overview of our Section 136 of the Mental Health Act. Like I said to you previously, this service is in collaboration with our police force. So when our police officers are on the street and they're needing some help and advice and guidance on individuals that they come across that believe that they're suffering from mental health sort of related issues, they can put a call into the mental health nurse. The mental health nurse will speak to them directly on the phone or phone them back, give them some advice and guidance, and hopefully to prevent that Section 136 from happening, or actually make the appropriate sort of intervention to detain that individual under Section 136 of the Mental Health Act. So next slide. And this was just our shared vision really, is we wanted to work together to enable people to lead healthy, independent lives and deliver care to them that's amongst the best in the world. So that's the end of it. end of my sort of presentation. Again, I'll let Terry come in for quickly. There is some patient experiences at the end of this slide deck, so really want you to read, get your tissues out because one of them is quite teary. But Terry, if you wanted to again come in, then feel free.
Okay, so just a quick observation before questions and answers, and in addition to what Sonia said, I think, and it's an acknowledgement for Sonia too, she's been really instrumental in driving this forward, so a big thank you on behalf of SCAS for that and the system. But from a SCAS perspective, the ambulance service is uniquely placed as well to look at the governance and resilience attached to crisis pathways, so if we get activity beyond the capacity of the mental health nurses, a clinical support desk can default to manage some of that activity, which is slightly different to some of the other option 2 models or other options available nationally. So I'm happy, along with Sonia, to answer any questions that anyone has.
Great. We're running out of time, but we have one question from Aidan Jordan Lewis. When people with mental health concerns ring 111, how many steps do they have to go through before they speak with a mental health nurse?
Terry, do you want to go for it because you've done it?
Okay, so there is an algorithm and a triage process to go through, and it is important to exclude any medical aspects to that. It is quite a quick process, and then people can be added on to the mental health queue for the nurses in the control room.
And a final question we have time for now is from Andrea King. How many were children and young people, do we know from your data?
We have, on average, Andrea, and I can actually forward it to you, there's about 60 to 70 a month that are under the age of 18. So our data set provides that. So Andrea, I'll send it across to you now.
Brilliant. Sonia, there's quite a few questions now coming through, but we've run out of time. Will you pick those up in the chat?
Yeah, I can do them in the chat whilst everyone else.
That's marvellous. And then we'll circulate them widely afterwards.
Yeah.
Thank you very much.
Over to Peter Gates, who I'm sure will introduce Jake.
Hi everybody, it's Peter Gates. I'm the Children and Young Persons Commissioning Manager for NHS England and NHS Improvement Health and Justice for the South East. So amongst a number of work streams, I lead on the commissioning of healthcare for our 3 secure settings for children and young people across the South East. And I asked Jake if he would be kind enough to do us a very quick overview of the Forensic CAM service. And if he gets an opportunity to also talk about how they've managed to sustain that delivery during this COVID experience, which has obviously had significant effects on practitioners' ability to deliver what would often be your kind of more traditional face-to-face type of interventions. Jake, are you there, able to pick up?
Hello, Peter and everyone. I am here.
So we'll hand over to you, Jake, if that's okay.
Lovely. This may be a bit late notice. Alec, I have forwarded some slides, actually. I don't know if it's a bit late to put them up. But if it is too late, I shall carry on regardless.
Carry on regardless, and I'll see what I can do.
Oh, lovely. Thank you. So a brief introduction, as Peter said, to the South East Community Forensic Child and Adolescent Mental Health Service. I will, yes, give a kind of a brief intro to who we are, what we are, where we came from, for those who may not be aware. So over the last couple of years, there has been an NHS England pilot scheme covering the whole country, 13 regions, developing these specialist community forensic CAM services. The initial reason for the pilot, for the project, being having identified a group of young people with a specific range of presentations and risks, which I shall come on to in just a moment. identifying the specialist needs and different groups of professionals and statutory provisions applying to this group, and the fact that, well, frankly, there were very, very few existing services. There were 2 or 3 services really around the country developed in isolation with local commissioning. So the goals of the national project were really to develop nationwide specialist services, looking specifically at this group of children and adolescents with complex mental health problems and presenting with risk to other people and high risk. Looking at improving the pathways for this population, particularly transfers between local services, secure services of all flavours, whether that be inpatient psychiatric services, welfare secure, or criminal justice, youth justice secure. And as part of that process, to develop really an outreach provision from secure services for young people. And obviously overall to look at improving the overall mental health and well-being of the. The plan has been very much to integrate these new services into the existing structure of local services and to complement those existing structures.
Jake, we seem to have lost you there.
Oh, hello?
You're back, thank you.
Can you hear me?
Tell me when to move on slide. Just
like lovely, you've got them. Fantastic, thank you. So yes, if we can have the next slide. So yes, this is what I was just talking about, the goals and the aims of the services. And next slide again. Yes, and here talking about very much being services which fit into the existing structures and complementing rather than duplicating. The idea being that these services will become integral to all the networks and agencies working with this population. And the next slide. So this is an overview of the 13 commissioning hubs and regions for the forensic CAMS services, and you can see us in a rusty colour down there in the southeast. And the next slide. And so this is the southeast region. So our service covers Kent, Surrey and Sussex, with a total population of about 4.5 million. Just to make the point here that we are a very, very small specialist service, and I'll come on to look at how we operate and what we actually offer. But to give a bit of a picture, so that's the geographical area we cover, about, to say, 4.5 million total population, and fully staffed we have about two and a bit whole-time equivalent staff in each of the counties, in Surrey, in Kent and in Sussex. So as I say, we're looking at kind of six or seven full-time equivalents across the whole of that patch. Next slide, please. So the population that I've been talking about, as I say, these services specifically developed to cover, the referral criteria in the population are actually deliberately broad because of the as I say, the identified complexity and needs of this population. But we accept referrals for young people, under the age of 18, but we have no lower age limit. Where there are concerns around mental health or neurodevelopmental difficulties, very much including learning disability and autism. And I would also say that we interpret mental health in the broadest possible context, so very much thinking about developmental trauma, chronic PTSD, attachment difficulties, and as I say, a very wide remit for mental health. And those who are presenting a serious risk of harm towards others, where there's a major concern in the family or professional network, and are in contact with or at risk of coming into contact with the youth justice system. We also potentially accept referrals for young people where there are concerns around high complexity of mental health needs and high risk behaviours. In a small minority of cases, even where those the primary risk may not be of violent offending or risk to others, but where there is particular complexity and high risk of challenging behaviours in the round, and particularly where placements may be at risk, or professionals networks are looking for advice around the suitability of appropriate secure settings. So as you'll see there, a varied and pretty broad remit. Move the slides on. Next slide, please. Slightly busy slide, just looking at the referral process. So we are open to referrals from all professional agencies, but obviously local authority, from youth offending, from education, from GPs potentially, from all sorts. We operate, as I say, we're a very, very small service, and we operate a primarily consultation liaison-based approach to working with professionals and agencies who refer in, and very much a stepped care approach. So initial brief advice, even preceding a formal referral stage, and that if that advice looks like it may be more in depth or may lead on to further intervention or assessment, we would at that point ask for a formal referral, which would lead to a formal consultation with the Forensic CAM service and the referring agency, and indeed any other professionals or agencies involved with the young person. And from there are a range of options. As I say, primarily we are a consultation, advice and liaison service, but we do have the scope to offer direct assessments, ongoing assessments, or even limited intervention work. I think, can we have the next slide?
Jake, you just have a couple of minutes now.
I think I'll be okay.
Brilliant. Brilliant. You're doing well.
Very briefly, this is the kind of the pyramid structure. So as I was saying, advice, consultation. In terms of direct assessment or intervention work, there are a range of things we might do. So we might offer diagnostic or formulation assessments in particularly complex cases. We might work with structured assessments of risk. People may have heard of things like the SAVRI, Structured Assessment of Violence Risk in Youth, AIM assessments for sexually harmful behaviour, and other structured formalised assessments. And indeed, in a small minority of cases, we may go on to work directly with a young person where there are particular forensic risks. Next slide. So yes, I think this is my last one. So that's kind of who we are. So very briefly, the story so far. We've been going for a couple of years. Our annual review with the NHS England Central team earlier this year, and the general story is that we're doing well. We're fitting in with the national picture in terms of our key performance indicators and the evaluation process. The pilot has become recommissioned now. Actually, we've recently heard. And although the initial pilot, and again, it'd be useful to think about this forum and linking in, jointly commissioned between specialist commissioning and health and justice, although that has now moved over to the specialist commissioning strand. And in fact, we have a meeting next week with the central team looking at the phase 2 of the provider collaboratives and where community forensic CAMs will fit in with the rest of the provider collaboratives and secure stairs and things. Very briefly, I mentioned we're a very, very small service, and that kind of six or seven whole-time equivalent Southeast is when we're fully staffed, and not just because of the recent problems with COVID, but we've struggled to be fully staffed throughout the whole of the project so far, and indeed we are still recruiting to some of those posts, which is a further issue. In terms of the COVID-19 response specifically, which I think initially we were on the agenda for, because of the nature of the service, really largely being consultation and liaison, a lot of that work has continued, moving online forums such as this and Skype for Business, etc. So a lot of that work has continued relatively unaffected. What we have seen is the need for support for the core services, the frontline services, where there have been staffing problems, where we're obviously concerned about resilience and well-being of our own staff and professional and family networks struggling, especially obviously with the schools being closed and the additional pressure on families. people were aware of the concerns again over the lockdown pandemic period of increased concerns around domestic violence and potentially childhood sexual abuse, and these are all very much issues that we think we're going to be kind of facing and looking at in the coming months and even years.
Jake, I'm going to have to call you to time, I'm afraid. And
can I mention one very final thing, just because I think it's so important and relevant, and that was around equality and diversity, obviously, in light of current protests and Black Lives Matter. One of the things that did come up at the annual review, really kind of following that same pattern, was the number of referrals we were getting for British young people, and being aware of the overrepresentation of BAME people within the youth justice sector. That's something that we are really actively looking at right now and conducting a local review of our referrals and demographics. We're done. Thank you.
Thank you. We've just got time for one question, and Gavin has put that in the comments, which is, could you comment on the degree in which FCAMS is integrated with the crisis care pathway within the region?
Yes, briefly. To date, we are not. Again, you'll see from the population and the size of the actual service in terms of staffing, we are not and are not able really to run as an emergency service or a crisis service. We are still in the process, really, of forming links and networks with the local crisis services. So we have good links, particularly was mentioned earlier, the police custody liaison and diversion service locally, which again is run out of Sussex Partnership, and we have particularly good links with the professionals working with young people in the police custody and courts locally. So we are not really directly linked in with the crisis pathway, other than the kind of the referrals that come into us, as I say, from those crisis services.
Okay, listen, thank you ever so much, and thank you for getting those slides to me. We got there in the end.
Thank you, guys.
Pete, I'm going to hand back over to you now, and I'm going to play with presentations to try and get us back on track onto the main set. And
right,
this is Secure Stairs bit.
Right, thanks, Alec. Thanks, Jake. I haven't actually got any slides because I've managed to squeeze in 5 minutes on this call, so it's just going to be a verbal overview. I thought, and yeah, thanks again, Jake. I think that there's some really good opportunities for us moving forward to be looking at how we're kind of linking up those kind of health and justice work streams with the sort of broader work going on with children and young people, crisis pathways, and opportunities to intervene earlier with young people who are in contact with criminal justice system. So just very quickly, we were hoping that one of the lead psychologists for the Secure Stairs programs from one of our secure settings would be able to present today, but unfortunately they weren't available. But I'm sure that at one of the future forums, they would be more than happy to come and give some detail about how Secure Stairs is being delivered in their setting. So as Jake described FCAMS, that's one of the work streams of our national colleagues around delivering the priorities for the long-term plan. So there have been three significant work streams around, in particular, sort of mental health and children, young people, and criminal justice. One of those being the FCAMS programme, another being what have been the collaborative commissioning network projects, but they're actually coming to an end. And then the third work stream has been the Secure Stairs work. Now, Secure Stairs is actually an acronym, but I am always mystified or unable to remember what each letter actually stands for. And in terms of how this will be described going forward, it's actually a framework for integrated care. So Secure Stairs it represents a significant investment in the funding for mental health provision within our all of the secure settings for children and young people across the country. For us in the southeast, that currently consists of HMY, Cookham Wood, and then we've got 2 secure children's homes. We've got Lansdowne, which is in East Sussex, and then we've got Swanwick Lodge, which is in Hampshire. In essence, the Secure Stairs programme is a recognition of the importance of delivering trauma-informed care and approaches to young people who find themselves in secure settings. Essentially a recognition that those young people are all significantly affected by their experience of trauma. It's largely made up of 2 particular approaches to working with those young people and supporting them. One of those pieces of work is around formulation. So it's very much around ensuring that there is a multidisciplinary assessment and ongoing discussion around that individual young person, their experience of trauma, and in particular, I think how that trauma may manifest itself in terms of behaviours, ways of thinking, ways of feeling, and in a lot of ways of managing their experience of being in the secure setting. So formulation is a large piece of the programme, but also hand in hand, and one of the pieces of work which I think reflects some of the other presentations given, which is around working up and delivering a really effective programme of support for non-clinical staff. So essentially it's about recognising that every contact with these young people in these settings counts. So there's an emphasis on developing an appropriate programme of reflective practice, in particular for non-clinical staff in those settings. Now, we found that the kind of models for that reflective practice have needed to be designed around that setting, because you've got kind of different environments, different partnerships, and different cultures in those settings. But in fact, reflective practice, we think, is going to be one of the ways that we really do deliver some change in the experience for those young people in those settings. Yep, thanks, Alec. And then last part of that is very much around a training programme around trauma-informed care, and again emphasising that training programme needs to be available for non-clinical staff, and that can can include administrative staff alongside education staff, alongside youth work staff. So the last 2 points really is one that just as a point of interest, in partnership with Kent County Council's Youth Justice Services, we have a pilot at Cookham where we're going to have 2 transitions workers who will be offering a very intensive casework approach to young people coming back into the community in Kent and Medway, and looking very much to sustain any gains around that trauma-informed care. And then last part really is, I think over the next 5 to 10 years, what many of you on this call will hopefully start to see is the work that we'll be looking to deliver across the LTP areas around how can we deliver that framework of integrated care, particularly for complex young people, and around designing earlier interventions to reduce that traffic into the secure settings. Is that okay? I'm a minute over, Alec.
Well done.
Okay, so any questions, if you could just pop those for Pete in the chat box. Pete, if you can just spend a couple of minutes picking off those as they do come in. Yeah. For time's sake, I'm going to move on and invite Stanley to come and join us. And Stanley is going to talk to us about how a safe haven has worked over the last couple of months. So Stanley, can you come on and talk to us, please?
Good afternoon, guys. Thank you very much for inviting me to talk this afternoon. Basically, this is a service that I'm extremely proud of, and we are proud of working in Northeast Hants and Surrey. So Aldershot Safe Haven is a service that's been operating since 2014. In essence, this is an out-of-hour services that has been largely driven by people using services, wanting an alternative environment, non-clinical environment, to get support during a period of crisis. And as such, some of the hours that we operate are a direct result of the requests that people using services and carers wanted us to provide. So initially in 2013, the Trust as well as the CCG worked together to sort of ask questions in a survey from people to really identify what sort of support they needed. It was essentially understood that NHS alone could not provide crisis care support without working closely with all the kind of partners in the county. And we've got a partnership arrangement with third sector organisation or voluntary sector organisation, together with the police, ambulance, and all the other sort of providers. We had a sort of platform as part of the Crisis Care Concordat to really work closely and understand how every single count of sort of encounter with somebody experiencing a mental health crisis might be able to be supported. So the next slide will indicate that where we've got sort of partners working in community, particularly police and ambulance, who essentially get some of the first responses to a mental health crisis, where there is no evidence of requiring conveyance to either a 136 or going to any department. That service user can actually be signposted or brought to Safe Haven, where they can be assessed by a mental health practitioner who is able to undertake an assessment almost akin to a practitioner who is working in a home treatment team or a psychiatric liaison team. We largely value self-referrals, where people have developed a capacity to recognize early symptoms or indicators of relapse, where they require kind of support, where carers are identifying that an ill relative is starting to get unwell. They can also encourage ill relative to be brought to our local Safe Haven services. We also know that GPs towards the end of the day sometimes struggle to sort of access crisis services. We also know that our Safe Havens are available now to support continuity of care for people using services. So, like I said, working in partnership with our third sector organization really puts the Safe Havens at the center of our community. So in developing our community resilience and encouraging people using services and carers to really develop self-management skills. Next slide, please. So what people might expect in our local Safe Haven is that this is an informal setting that is non-clinical, that you expect that you will be treated with warmth, respect, and without judgment. It's important, of course, to be treated with dignity, care, and compassion. There is easy access to qualified professionals. We also actively seek to recognize carers who are doing a fantastic job supporting people in the community, so that their needs can also be identified and supported. We are closely linked to all the pathways within our community, including community mental health recovery services, and our home treatment team, just in case people are acutely unwell. Next slide, please. So the beauty of Safe Havens, and this is the bit that we're really proud of. So anyone who is experiencing a mental health crisis can basically just pitch up and turn up into a local safe haven and be supported, safe in the knowledge that they've been supported by somebody who's competent, who can assess their needs at the point of crisis. We also require our practitioners to be able to sort of facilitate urgent and emergency sort of access to crisis care where that's indicated. In essence, I think we do encourage people that have not got medical sort of presentations. So in the absence of people taking overdoses or self-harm, people can be supported. There has been sort of occasions where, very minor occasions, where we've had somebody turn up having taken an overdose, but our practitioners are able to deal with situations like that and support people accordingly by liaising with our general hospitals and our liaison counterparts. Essentially, recovery and crisis support really ought to sort of stay well connected. So we know that people often go into lapses where they dip into relapses, but recognizing that people can be supported to stay well by reminding them of their crisis and contingency plans will go a long way in supporting them to prevent future crises. You don't really need an appointment. So if you need support, just pitch up and you can be supported. So as a response to our sort of COVID, we obviously quite quickly looked at the situation and felt that we needed an active response. In essence, our service ordinarily sort of depends on people visiting the safe havens, but because of the lockdown, it meant that people couldn't access our service properly. So we sat down with our people using services and felt that we really wanted to continue to support them. Our safe haven staff were amazing because they wanted to continue through the lockdown to offer face-to-face support, and we continue to support people in crisis. For those that were self-isolating and people shielding, and for those carers that were not able to visit our safe havens, and for those as well that were in remote locations, perhaps if people are familiar with Surrey, some places are quite difficult to sort of access by public transport. So the virtual platform gave us a really good sort of way to reach out to people that were not able to access us. So the service coalesced quite nicely with our safe havens. It is provided by, again, really competent people who know the cultural sort of environment of where they are working. Next slide, please.
Stanley, I am going to move you on. You're running dangerously out of time, and there's quite some interesting questions for you.
Thank you. So having done our scoping, we were able to sort of ensure that we continue to provide the two services together, and we're getting some really interesting sort of feedback from people using services because they are quite keen for us to continue to provide the virtual offer. And again, if in some cases where it's not appropriate, we can always call people to come in and get support from our local safe haven. There is a quick slide about demographics that I really wanted to share with people. As you know, Aldershot Aldershot town centre is sort of quite a military town. We've got a large population of Nepalese. We are quite keen to sort of increase reach in that locality. So we're working really hard with local communities to be able to provide support for that population. And some of the interesting feedback on the last slide is that people are really finding the virtual offer really useful, and it is something that we would like to continue to provide. I'll end there in the hope that I'll be able to sort of take a couple of questions.
That's great. Stanley, thank you so much. Yes, so first question was, how's your activity been during COVID?
So initially, our activity was quite low because I think people quite rightly responded by not coming out to seek support, but it's steadily increased over the past sort of few weeks. And also we know that we've got about 3/4 of people actually presenting in person and 25% sort of in virtually. So the numbers are continuously increasing.
And just very quickly, how does the service help people who are high risk, or do they advise detaining under the legal framework?
So we generally don't take people who are under the legal framework. Of course, the police officers, say for instance, would pick somebody up. They've got an option of how to respond to that service user. In some cases, they will have to detain the individual and take them to an assessment suite, which is local. But in the absence of that, and there is no requirement to use a mental health act, they can also signpost to the safe haven where a service user can be supported and assessed.
I'm going to skip over the CYP questions because I think they've been answered, that there is a CYP Havens in Surrey as well, so that has been answered in the question.
That's great.
Lawrence Mascarenas can provide information for that, who's also on the call. So Modesta from the national team, Stanley, is asking a couple of questions. Do you collect PREMs? If so, how?
So we are sort of in the process of actually trying to do that. I think this is something that was recognized as part of the evaluation when we did the Vanguard. As part of the Vanguard, we would like to sort of do that, but we do have our own surveys that we've collected over the past few years that can provide some form of sort of outcomes in terms of the people's experiences, but not proper sort of PREMs, but it will be something that we would like support with.
Okay, for those of you that have put in questions, I do apologise, we have run out of time. Stanley, if you do get a chance, can you just go onto the chat and maybe answer a couple of those questions after Modesta's there, because yes, I do have run out of time. So just to wrap up today, firstly, I would really like to thank everyone that's given up their time and come on and presented today. I really appreciate you doing all of this and giving us the opportunity to talk to a broad set of people. Sylvie, myself and Pete are very keen on making sure that we run some more of these events through either the end of this year or indeed going into next year, and we want to make sure that we're hitting the mark. We want to make sure that we're delivering something that's helpful to you. Therefore, as you'll see up on the screen now, we've created a very short survey. It's only 10 questions. SurveyMonkey tells me it'll take you a grand total of 4 minutes to complete. So we're going to finish before the end. Therefore, I'm going to ask you to go to that survey. I'm also hopefully just throwing it in the chat, and I hope that works, that you can follow the link via the chat there right down the bottom from me. So you should be able to click on the link directly. As I say, we really would appreciate if you just took the last few minutes of the time here today to go and help us essentially help you. So I really would like to just, Sylvie, is there anything else you'd like to add to the end of that?
No, just to reinforce, thank you to everyone that presented. A highly interesting afternoon, from my perspective anyway.
Much appreciated. Pete, as the other co-chair, anything you would like to add?
No, just like to say thanks to you and Sylvie actually for keeping us focused. There was a lot of people dialed in and a lot of content, so well done to both of you.
Thank you.
Okay. So thank you, everyone. We will now close this down. I will just leave this open and running just so people can go onto the SurveyMonkey and click on that. Really appreciate it. Thanks all, and goodbye.
Thank you.
Bye. Goodbye.
Bye.